So my topic is very clinical and very simple. Some clinical tests are there. So coming to the evaluation of the nasolacrimal system. So coming to the anatomy, lacrimal tear is produced in the lacrimal gland. Then it comes to the puncta located at the posterior edge of the lead margin. Canaliculi passes vertically 2 mm, then turn horizontally, medially and horizontally for 8 mm. The superior and inferior canaliculi unite to form common canaliculus which opens into the lacrimal sac. So lacrimal sac is around 11 to 12 millimeter long, lies in the lacrimal fossa. Lacrimal bone and frontal processes of the maxilla separates the lacrimal bone from the middle meatus of the nose, and the nasolacrimal duct is 12 to 18 millimeter long, and the opening of the duct is open in the inferior meatus of the nose. So in the level of the inferior meatus of the nose, there is a mucosal fold that is called valve of Hasner. So coming to the physiology of the lacrimal system, the tears flow along with the lower marginal strips, pulling into the lacrus lacrimalis medial to the puncta, then entering to the canaliculi by capillary suctions. And with each bleeding, the preseptal auricularis oculi muscle compresses the ampulla of the canaliculi and closes the punctum, resisting the reflux. Here, this is resisting the reflux, and the contraction of the auricular oculi muscle creates a positive pressure that forces the tears down to the nasolacrimal duct into the nose. This is the nasolacrimal positive pressure building of the contraction of the auricular oculi muscle, and the tears goes into the nose. Then when the eyes open, the canaliculi and sac expand and creating a negative pressure, and that draws the tear into the sac. Here we can see the how the after opening of the eye, the tears goes into the sac. So there is always a balance between the production of the tear in the lacrimal gland and the drainage. So when there is an imbalance, that may be secretory epiphyra or excretory epiphyra, that is the watering of the eye occurs. So coming to the epiphyra applies to excessive tearing caused by excessive tear production or secondary to the poor drainage. There are so many causes of the epiphyra. Punctum causes are 35% due to the punctal stenosis, membrane in the punctum, punctal ectropion, punctal plug, etc. Canalicular causes consist of 15% stenosis, infections, scarring due to the viral infections, and the nasolacrimal duct causes may be 24% due to the primary acquired nasolacrimal duct obstructions, trauma to the nasolacrimal duct, and the lacrimal pump failure, which is consist of 11% due to the involutional eyelid laxity in the in adult and old age, cerebral palsy, pseudo epiphyra, which is 11% due to the dry syndrome, and the nasal and sinus disease consists of 4% of the cases due to the polyps, sinus tumors, sinus surgery, etc. So coming to the examination of the epiphyra, this consists of proper history, examinations, clinical test, by which we can come into the complete conclusion to pathology of the nasolacrimal duct system. So coming to the history, inquiry should be made about the ocular discomfort and redness to aid in excluding the hypersecretions. Drainage failure tends to be exacerbated by cold and windy environment. A complaint of tears overflowing into the cheek is likely to indicate drainage failure rather than hypersecretions. So external examination is the puncta and eyelids should be examined thoroughly under the slit lamp microscopy. There will be an obvious tear outflow from the medial or less commonly from the lateral canthal region. Visible micropurulent discharge is more likely to occur with nasolacrimal duct obstructions, and punctal stenosis has been reported in the half of the cases here due to the conjunctival salicis patient with the watering, and this is the punctal stenosis. So lacrimal sac should be palpated Punctal reflux micropurulent material on compression is indicative of mucocele with patent nasal canalicular system, but with obstruction of the nasolacrimal duct. Ectropion usually associated with the secondary stenosis. Occasionally, an eyeless may be lodged in the ampulla, and porting punctum is typically of canaliculitis. This is a porting punctum, which is a cause of canaliculitis, and a large carancule with the associated canaliculitis. There is a cilia which may be plaque in the punctum, and this is a case of medial ectropion. So coming to the test, fluorescein dye disappearance test. This is a very important test. 2% fluorescein dye is instilled in the both eye. Then observation are made after 2 minutes. Normally, no dye is seen in the conjunctival sac. A prolonged retention of dye in the conjunctival sac indicates a drainage which may be due to atonia of the sac, that is the lacrimal pump failure, or maybe due to the mechanical obstructions. So regurgitation test, gentle pressure over the lacrimal sac. Then if the regurgitation from the upper punctum indicates block in the lower canaliculus or punctum along with the nasolacrimal duct. A regurgitation from the lower punctum may means block in the upper canaliculus or punctum. So pressure of the sac with no regurgitation may imply there may be a patent nasolacrimal duct, there may be absent sac, patent DCR or intubation of the NLD or sac, encysted mucocele of the sac, or recently emptied sac. So characteristic of encysted mucocele of the sac may be distended, non-tender and tan sac, a non-compressible swelling, no regurgitation from any of the punctum, or no epiphora. So test. So lacrimal sac is communicates with the conjunctiva and in on the nasopharynx of the other eye. So any fluid which can be instilled in the eye maybe can be tested in the mouth. So 5% sodium chloride drop or 5% glucose saline or any other antibiotics, usually the chloramphenicol, because its better taste, can be used. So if the block is suspected in unilateral, then any drop of the put in the ipsilateral conjunctival sac. Absence of the test denotes the NLD block in the same side. The test is positive when the lacrimal passage is open, and it is also positive in case of partial nasolacrimal duct obstructions with positive regurgitations. If the block is suspected one side, then the test of the first eye side is tested, second eye is tested after 48 hours. If the test is not felt after 15 to 20 minutes, there is a complete block of the nasolacrimal duct system. So coming to the important test is the syringing test. There should be a sterile kit for it. The test is performed to find out the patency of the nasolacrimal duct, patency of the DCR, patency of the lacrimal fistula to partially open nasolacrimal duct. So here the procedure: conjunctival sac is anesthetized with 4% xylocaine or paracaine. Lower punctum and canaluculus are dilated by punctum dilator. Lacrimal cannula is introduced to the dilated punctum and the canaluculus, and the lacrimal cannula is attached to a 5 cc syringe with a normal saline. So after slowly push down, the following observation can be made. Patient feels the saline in the throat, that means nasolacrimal duct system is open. Saline is felt in the throat under the pressure is partially blocked NLD. Saline is not felt in the throat and regurgitation through the upper punctum, that means NLD is completely blocked. Saline regurgitates through the lower punctum by the side of the lacrimal cannula. Then nasolacrimal duct, upper canaluculus and the punctum are blocked. Saline trickles through the opening through the skin, that means that there is a fistulous opening in the sac. So coming to the Jones test, this has two tests, primary and secondary test, to differentiate the partial obstruction and the lacrimal pump failure from the primary hypersecretion of the tear. A drop of 2% fluorescein is instilled in the 2% fluorescein is instilled A drop of 2% fluorescein is instilled in the one eye only. After about 5 minutes, a cotton tip bud is moistened. The local anesthetic is inserted in the inferior turbinate. A positive fluorescein is recovered in the nose indicates the patency of the nasal lacrimal duct system. Negative test, no fluorescein is indicated that there will be a partial obstruction or there may be a nasal lacrimal duct failure. Here we'll go for the secondary irrigation test. It identifies the lacrimal pump failure or probable site of partial obstructions. Positive fluorescein stain saline is recovered from the nose indicates that the fluorescein is entered in the sac. That means it's a partial NLD block. And negative unstained saline is recovered from the nose indicates that fluorescein did not enter the sac. That means there is a lacrimal pump failure. So coming to the radiological test, contrast decocystography. Decocystography involves the junction of radio-opaque contrast medium onto the canaliculi, followed by capture of the magnified images. It is valuable in patient with mechanical obstruction. It tells the exact site and nature of and extent of the block. It also gives the information of the mucosa of the sac and the presence of fistula, diverticula, stone, or any tumor of the sac. Here is a both side pattern nasolacrimal duct, and here there is a left is normal filling of the nasolacrimal duct system, and there is a block in the junction of the sac and nasolacrimal duct.
The speaker is not.
So commonly used dyes are Conrad 280, neohydral, and diagonal viscous, lipoidal in water or oil, and dianosyl. Types of decocystography are plain decocystography or macro decocystography. Plain decocystography. Plain decocystography, the dye is injected, the lacrimal cannula is removed, and lateral and AP axis orbit are taken. Macro decocystography, here the sac is distended with eye throughout the procedure without removing the lacrimal cannula. The lacrimal cannula is attached to a long polythene tube and connects to a 10 ml syringe and containing the dye. Dye is injected to distend the sac. Anterior posterior x-rays are taken immediately and repeated 15 to 30 minutes. So radionucleotide assisted decocystography. Scintigraphy assesses the drainage of upper and more drainage under more physiological conditions, and decocystography by labeling the tears with a radioactive substances. It may identify the location and partial or functional block to confirm the functional obstructions. Laser is used to evaluate the anatomical as well as functional block. Here we can tracking the tear which is coming at different levels with the help of radio tracer material. So CT and MRI are occasionally employed in the assessment of lacrimal obstruction, for instance, investigation of paranasal sinus or lacrimal sac pathology. Here there is a lacrimal sac tumor can be seen in the picture. And internal nasal examinations to assess the nasal cavity, especially in endoscopy, can be evaluate the nasal cavity to especially evaluate the blockage at the different levels, can be valuable to detection of obstruction such as nasal polyp or any nasal pathology. Thank you so much for your patience here.
Thank you, Dr. Pankaj.
Thank you, sir.
Any questions? Any questions?